Welcome back to a patient from India. He's a young 26-year-old guy who was having symptoms for the last 7 years. Echocardiogram showed features of pulmonary hypertension. He was given 2 pulmonary vasodilators, sildenafil and bosentan. He was also giving anticoagulation and potassium-sparing diuretics. He worsened to NOHA class 3 in the last 6 months. He had repeated episodes of syncope with very minimal exertion. He is a well-built man weighing around 84 kg, saturating normal. He had clinical examination showed prominent A waves on the JVP. His 6-minute walk distance currently is just 200 meters. X-ray shows a bulge in the main pulmonary artery segment. Next. The ECG shows a rightward axis. The QRS axis is plus 140 to 150. There is a right ventricular hypertrophy with RV strain pattern. You can see the echocardiography. RV is significantly dilated. Intraatrial septum bows into the left. Interventricular septum bows into the left. RV is having severe dysfunction. This is the inferior vena cava. The atrial septum is actually bowing into the left atrium. This is a subxiphoid short axis view. The right ventricular systolic pressures were nearly 100. Next. Maybe 90. There was significant IVC congestion. The right ventricular indices of contractility were low. RV free wall strain was low. The TAPC was low. There were no evidence of thromboembolic pulmonary hypertension. The pro-BNP was 1,600 picograms. There are no evidence of connective tissue disease. There are no evidence of portosystemic shunts or liver cirrhosis. He was on a mildly elevated levels of TSH, is getting optimal thyroxine supplementation. So he is a patient with idiopathic pulmonary hypertension on follow-up for the last 7 years with severe RV dysfunction, progressive venous congestion, NOHA class deteriorating to class 3 with repeated syncopal episodes. Nick, what will you do?
First of all, I have to thank you that with 84 kilos, you call him a well-built gentleman. So that's encouraging myself. That's the first thing. Thank you very much.
I am taking into consideration the Indian standard weight.
That's okay.
Okay.
But I think you've put it on the point. This is the patient with severe, very likely idiopathic pulmonary hypertension and right ventricular dysfunction. And the recurrent episodes of syncope indicate that there's a recurrent suprasystemic pulmonary arterial pressures and resistance. So the options are, despite all this medication, to relieve the breakdown of the circulation by creating an interatrial shunt. So that's the possibilities you have in this gentleman.
So
the problem though will be, as you see on the echo, transseptal puncture is pretty dangerous in these patients because first of all, it's difficult to find a spot in the atrial septum on the right side where you can anchor your needle. And second, when you pass through, there's not much space. So you have the potential risk of injuring the left atrial wall.
Yeah, correct. So how do you, okay, now what you're seeing, can you show the fluoro, you are already seeing the hemodynamics. The yellow color is the pulmonary artery pressures and the red is the aortic pressure. You can see that the systolic pressures are almost the same. Now it is actually the PA is marginally going higher than the aorta. And the diastolic is marginally lower. You see, this is the sort of yo-yo pattern. We have been seeing the PA pressure going little above. Now you see that the PA goes a little above. I think during one of these episodes he gets a syncope where the systemic pressure drops down.
Can you give us information about the right atrial pressure? Because, Sandoval proposed to do these procedures, in his case with balloon atrial septostomy, with right atrial pressures between 10 and 20.
Okay. Now, I'm going to give a pull back from the pulmonary artery back into the right atrium now. So we are having the catheter in the pulmonary artery. So
Just
we are
one question before: left atrial pressure or left ventricular end-diastolic pressure. You have any information about those before you look at the others?
I can show that right now to you. Okay, I'm first pushing the left ventricle. Give me a wire.
Or wedge pressure from the pulmonary artery?
No, we didn't wedge, because anyhow I'm going to puncture the atrial septum. Okay, enough.
There you go.
So now I'll give you the left ventricular end diastolic pressure. The criteria for safety of the septostomy is the left ventricular end diastolic pressure should not be very high. Here it is around 5 to 6.
Okay, thank you.
And now the left ventricular end diastolic is around 6. Now I'm coming into the aorta. Show the aortic pressure. Show aorta and PA same scale. Yeah, now I'm pulling back from the right put it on 200 scales. So I'm coming down from the PA towards the right ventricle. Right ventricular end diastolic pressure is higher than the left ventricular end diastolic pressure. Show it in 20 scales. 20, yeah. It's around 14 to 15. I'm coming into the right atrium now. This is the right atrial pressure. Right atrial pressure is a mean of around 8, with a wave of about 14 and V of around 10. Is the pictures clear there in the screen?
The pictures are clear.
Okay, a couple of days ago when I was there, the Congress theater was like having a lot of light from the surrounding area, and sometimes if you are not sitting in front of the screen, then the pictures were not nicely visible. So in order to facilitate the procedure, we have an intracardiac echo. Dr. Raghuram, who is my colleague, has already set up the intracardiac echo. You are able to see it's online now. It's what you are showing is not recorded. It's just live, right? Okay, fine. So what we are seeing is I can now manipulate. Yeah, that is the septum secundum. This is the septum primum. So we are going to be planning a septostomy based on intracardiac echo. Can I have a wire, please?
So, Shiva, before you continue, just a little discussion. Number one, if you have a right ventricular end diastolic pressure of 18, how can the RA pressure be only 8?
See, this is a sort of you saw that the right atrial A waves were quite taller. Basically, it's a compensation when the end diastolic pressure is high, the atrial pressure alone goes up and tries to maintain the mean pressure little low. Once the tricuspid regurgitation sets in, then the V also starts to go in, and then at that particular point of time, then the entire RA pressure starts getting elevated significantly. The second point is this patient has been fasting from yesterday night, and so some degree of the intravascular volume also may be marginally be lower. There won't be any doubt when you look at the intraatrial septum that it is significantly bowing into the left atrium on the intracardiac echo that we have positioned. I may not be surprised if the left atrial pressure is much lower than...
Yes, but the other thing is there has not been a very substantial tricuspid regurgitation.
Yes.
And you have just measured the left ventricular end diastolic pressure with 6.
Yes.
And if the pressure gradient would only be 2 millimeters of mercury, there would not be such massive bulging from the right atrium to the left atrium. Don't you agree? So there must be a much higher pressure difference between the right and left atrium.
I would probably anticipate a left atrial pressure now of maybe around 2 or 3 or something like that. We can give some little bit of fluid. Slowly can you run about 200 mils of saline. So
okay, now your plan is to go for a transeptal puncture. You will talk us through that. And then you would like to implant an AFR device. Could you give us your thoughts about the size of this AFR device? What would you choose and why?
That decision will be taken after I get the left atrial pressure and look at the left atrial pressure. If the gradient is quite a lot, I would like to put in an 8 millimeter hole, or in majority of the adults, I'd like to put in a 10 millimeter hole. You can appreciate the amount of spontaneous contrast that is floating around and it stays for longer time, indicating that there is quite a sluggish circulation. I didn't tell about the pulmonary artery and aortic saturations. In room air, the PA saturation was 58 and the aortic saturation was 98, indicating again a wide arteriovenous oxygen difference, indicating low cardiac output. Is the contrast connected? Fine. So right now what we are doing is we are doing a broken brow septal puncture. I'll show the needle. Can you show the needle? Put your finger here. I have given a little extra bend. Can you show my hand? Hand bigger. Hand, yeah. So I have made a little bigger bend on the needle. So right now we are going through. No, don't flush. Show me the groin. So we are going through the sheath into the heart. Okay, the needle is ready. I'll get the come here and get the eyes continuously showing me this part. Okay. So Dr. Santosh, he's my colleague. He is going to be showing I'm using multiple markers. I'm using fluoroscopy as well. Prabhu, are coming down. So I am still in the superior vena cava. I have not started getting an atrial ectopic. So now I am falling into the atrial fossa. Okay. At this point, I'd like to rotate my. Can you see the indentation?
Yeah, now it's clear. Very good.
Rotate it, Santosh, till you get. Okay. Still, I am going for certain fluoroscopic markers as well. Come to RA of 40. Keep live. That don't freeze the image. Yeah. So in RA of 40, I am getting my transseptal needle anterior to the descending aorta. Lateral view. The patient is conscious. He is listening to me. He's a computer science graduate. Okay, now I would like my needle to go a little to the. Okay, now let me see whether I am still. Yeah.
I think the most information you get is from your echo.
Okay, fine. So now I am slowly jabbing my needle inside. So now I am using my transseptal sheath to pop inside.
Now you're through, yes?
Yeah. So that is the intracardiac echo showing my sheath through. I have taken my needle out. I'll give a small puff of contrast and then I will connect you to pressure. We have to remember that I have told my nurse to give a 200 ml bolus. So let me see what is the. So I'm in the pulmonary vein now.
Yes.
Yeah, show the LA pressure. Get on to the LA pressure, show it in low scales. Low scales. Put it on 5 scale. Yeah, it's hardly 1 or 0 or something like that. Sister, we can give another 200 ml more. So there is a 8 millimeter at the right atrium and 1 millimeter at the. In fact, it's going even a little bit low. Can you see that, Nick?
Yes.
So ideally, I would have done it early in the morning when in my normal routine cath lab day. I would tell you today, this is now 2:15 Indian time, and this transmission, so there was a slight delay in the timing of like if I had done in the morning, it would have been a little better pressures. Now show it
So
in
this,
show
so
it in low states.
this gentleman is now fasting for 24 hours or something like this.
Not 24 hours. Yesterday night he had his dinner, and the
Okay.
morning he didn't have his breakfast. Yeah. So now we are pushing fluids, and little bit the LA pressure is coming up. Okay. So now what I'm going to do is pass a stiff wire, and through the stiff wire I'm going to advance a 14 French stiff wire. I am already in the left upper pulmonary vein. Heparin we give, sister? Full 5,000 heparin. Yep.
Now, before you pull back your sheaths, could you give us the chance to have a pressure pullback? Because now you can take the pressures left atrium, right atrium on the pullback. Is that possible?
It is not possible with the sheath that I have used. I am actually, what I have done is I have used a transseptal dilator alone. I have not used the whole sheath. One of the reason is, if I accidentally jab inside, I will have only the needle tip, or at the maximum, a tip of the dilator. So it has been my practice just to push in only the dilator, and now I am going to exchange it entirely. So currently I am putting in a thermo wire, and this thermo wire now I will exchange it into the Judkins right catheter. Has Dietmar come back?
Not yet. Still partying.
Tell Dietmar that I didn't like this. I was expecting him to shout. He likes creation of PDAs, ASDs. He wants everything to be open actually. Okay.
He wants to be open-minded, let's put it like that.
Exactly, correct. So now I am exchanging this into a coronary catheter. Right coronary catheter. And now I am going to take a stiff wire. We don't have the luxury of using radio frequency gadgets for septal punctures. How do you do it, Nick?
In the way you do it, same procedure.
Okay.
At which point of the procedure do you heparinize the patient?
I have already heparinized. The moment I did the septal puncture, I heparinized. Until that time, in order to prevent the catheters from getting a thrombus, we were actually flushing it frequently. But the moment we did the septal puncture, we have given 5,000 heparin. From now onwards, the procedure should not take much time. 14 French sheath, please. So we take a Cook Mullin sheath 14. No, this one. Make it faster.
And now you have an extra stiff wire or ultra stiff wire in the pulmonary vein.
Yeah, this is one of the extra stiff wires. Amplas extra stiff from the Boston Scientific. I'm just groin dilating. Relax. Are you having pain? Relax. It's only this dilatation part will be little painful. Can you give a little bit more xylocaine? The groin. Relax. Okay. You keep watching the screen. We have crossed from the right to the left chamber, and we are going to put in a small buttoned device which will have a specified hole. Okay. Relax. Give me some xylocaine in the groin. It's important to give sufficient amount of local anesthesia because they should not get into. Show me the aortic pressure. Keep on showing me the aortic pressure. put it on 200 scales. Yeah. Yeah, that's fine. I'm infiltrating a little bit more xylocaine. Hold, relax. Hereafter it won't be pain. I have given you some painkiller medicine also in that area. It's actually passing through quite well, so that means the portion of my septal puncture is possibly a little thin. You can appreciate that I'm going actually through the septum primum. Can you see that, Nick?
Well, I see it's a thin septum, but whether it's a septum primum, I would not
I
totally
will show
agree.
this. That is a septum secundum on the top, right upper quadrant, 2 o'clock position, and that's a septum primum. See that? You see that? You see the thickness? That is a septum secundum on the rightward side, and the sheath is going through the left, like the fossa.
Let's agree it's a thin part of the septum.
Yeah. So now I'm going to be taking out the dilator. Open out at 10.
Shiva, I can tell you a surprise.
Yes.
There's a gentleman just coming in, and he's not wearing a tie. So guess who could it be?
பயப்படாதீங்க, relaxed இருங்க. Yeah, is it Dietmar? Hi, Dietmar.
Hi.
You
Very happy to see you and hear you.
Yeah.
Very well.
Dietmar, I'm doing something that you will always like. You like creation of atrial septal communications, right?
That's true.
Yeah.
Restrictive atrial communication.
Yeah, restrictive atrial communication. This is a gentleman, young fellow, who was having repeated syncope due to idiopathic severe pulmonary hypertension. He has been receiving a lot of pulmonary vasodilators, but still he is quite symptomatic with repeated syncope. So what we were doing was an intracardiac echo guided septal puncture. So now we have got the septal puncture through. So the sheath is in now. Can you open?
Shiva,
Yep.
Shiva, one question. Would it be possible, I mean, the wire is now out, to have a pullback? You have the different filling situations, have a pullback from the left to the right atrium. So we have some comparison about the pressures that exist now at the moment.
I will do that. Can you get me the
Do we have
stiff wire again?
One question or comment from the audience, please.
Yep.
How do you avoid a very common problem in a semi-awake patient with a very low LA pressure and such a large sheet of air bubbles sneaking into the left system in spite of what we do?
We put the Cook Mullin sheets check flow. The side arm was passed through a was kept underwater seal, and then can you give me the thermo wire, or can you give me another wire, amplitude superstrip? We put it on underwater seal, and we take out the dilator quite slowly. So now, since Nick wanted a pressure pullback, I am passing again the stiff wire, and I am going to take a pullback. Yeah, JTP is fine. Get it inside.
Can we have a question from the audience? First of all, congratulations. These are very complex procedures in very complicated patients. In some of these patients, you get an acute desaturation. How do you control for that?
Yeah.
And they decompensate rather quickly. And have you given any thought to, instead of an intra-atrial shunt, a percutaneous clot? And do you have any experience with that?
Okay. The patients who are likely to have very severe desaturations are those patients who have very high right atrial pressures, more than 20 millimeters of mercury.
Yeah.
The patients who are already having a resting saturation of less than 90. So these are two groups of patients which has been identified on some meta-analysis to have a higher procedural morbidity after a balloon atrial septostomy. So the general rule is, if the RA mean pressure is more than 20 and the resting saturation is less than 90, you don't do a balloon atrial septostomy. Now, now can we look at the pressure pullback? Now this is the left atrium. Make the pressure bigger. Make the pressure big. Okay. Now the LA pressure is around 1. So I want another 200 ml more. So now I am slowly coming out. That is RA. Can you see that? RA is quite a lot. Okay, put it on 20 scale. We have been giving a lot of fluids now for the last few minutes. The LA continues to be 1 and the RA is now 17, 18. Sister, stop it. Stop
Siva, with all due respect, 400 mils of fluid is not a lot. I mean, this is just refilling a little bit to normal situation. And that's what I asked you. If you have an RA, right ventricular end diastolic pressure of 18, the RA pressure should be 18-ish something. And this is how the echo looks like. So this is why I was a little bit, let's say, suspicious with the initial measurements.
Okay. Now this is the left atrial pressure. Put it on LA. LA is still very low. So now that given this sort of very high levels of pressure difference, I will be tempted not to go for a 10 millimeter, but probably I might go for a 8 now.
No. Shiva,
Yes.
you mentioned just 20 millimeter of mercury is a official guideline related contraindication for creating an atrial communication, let me say atrial
Exactly.
But consider if you have 18 now that I would not go over 4 or 5 millimeter because the hypoxemia.
Show the aortic pressure. Show the aortic pressure. He's actually getting a seizure once again. Wait.
Like
Connect
a
oxygen. Give it the aortic pressure. You see the aortic pressure now. Okay. Give the aortic pressure now. Can you start on some norepinephrine, Martin? Call
It's a hypotension. You have to give a little bit
volume.
norepinephrine.
Norepinephrine.
But with
Now this is exactly the type of syncope that he used to get. You see that?
Yeah.
Okay. Now I'm going to be putting in straight away an 8 millimeter AFR immediately, not to lose time. See, his left
make it 4 or 5, 6 or 4 or 6, not more.
No,
Please.
8. Open an 8.5. Fast 8.5.
8.
8.5.
Do
Exactly.
you have
See,
ilobros there?
what is
Do you
that?
have ilobros
No,
for
we don't.
inhale?
No. We have.
Okay.
We don't have any prostanoids.
Okay.
What we have is IV sildenafil or nitric oxide, but he was a nitric oxide non-responder. A short while ago, we checked this nitric oxide response. He didn't respond.
Okay.
Connect. Illa, sister, leave it. Okay. Just open. Okay, leave it. Okay, fine. Connect. Okay, now
So
quickly I will show you the device. See, the time is running short, so rapidly focus on my finger. Okay, that is the device. I'm taking an 8.5 AFR. This was actually, he's continuing to have. I'm putting the systemic pressure continuously for you. Give the fluoro live. No, don't show my finger. What I need is the fluoro and the systemic pressure both together. Systemic pressure line, bigger screen,
Is the patient ventilated spontaneously?
spontaneously ventilating. Yeah.
Is he on 100% oxygen?
Yes. Currently he's on 100% oxygen.
Okay.
Yeah. Now. Okay.
And do you have bicarbonate, sodium bicarbonate? You have that available?
I'll once again. Okay. Currently, can you show me the intracardiac echo? One person. Get a blood gas done.
No. Don't do blood gas. Just give 50 ml sodium bicarbonate. Just do it.
Aortic pressure is now bounced back nicely. Okay. Now the pressure is now, aortic pressure is fine.
Yeah.
So now let me interrogate the atrial septum now.
Yeah.
Okay.
what size device did you use now?
8 millimeter. Color this one. Color. Yeah. Okay. See the problem about intracardiac echo, sometimes it doesn't give beautiful color. Can you see the color? Like slightly increase the.
Sure, we see it.
Yeah. Slightly increase the color gains. The pressures are okay now.
Okay. Shiva, please do not release the device. Let's just take some time. The patient is now stable.
Yes.
You have made everything correct. And now we have a little bit time to think.
Okay. Now you can see the flow pumping from the RA into the LA. It's
Patient
actually,
is breathing. The blood pressure is there. We have time.
yeah.
And consider the oxygen saturation
Keep
now.
on
Exactly.
giving oxygen, then we'll see. Yeah, right now he's having a saturation as I speak to you of 62, but I'm going to keep watching.
Yes. 62, and he's on 8 liters of oxygen
No.
or something like
Yeah,
that.
he's on oxygen, but he's yet to completely coming out of the syncope. How are you now? You're okay? That giddiness is slightly better? Still feeling giddy? Okay, relax. Just breathe. Don't worry, relax. I'm going to take one blood gas now. Get me one syringe. I'll take from the descending aorta. So this is actually he was getting repeated episodes of syncope on routine day-to-day activities in the last few months. So many episodes of syncope, and he's experiencing one such syncope right now.
How much heparin you have given before the intervention and the ACT? What is it now?
We have given 5,000 heparin just about 15 minutes before. The procedure was not going on for a long time. Okay.
Sometimes it's even effective if you have only some bubbles. And
No, actually, he's talking to me. He says that he's feeling giddy, a sort of dizzy feel, and he's just coming out of it.
so what is the right atrial pressure now and the oxygen saturation in the systemic circulation? That is now most important for the decision making. You reduce to 6 millimeter or 4 millimeter device or not?
Yes. Right now, I have taken the blood sample for gas analysis. The pulse oximeter is recording 67 right now. He's still yet to fully
again. Shiva, look in the echo. You have a lot of bubbles, and be careful for any intervention now because it is all crossing to the left side.
Yeah.
I have seen it in the right atrium that is full of, let me say, air bubbles.
Yeah.
Be very, very careful now.
Yeah. RA mean pressure is now 13.
Okay.
Saturation is 76. I'm just waiting for him to completely come out of the episode of the syncope.
Do you have an ACT? I think we all learned that the effect of heparin is very unpredictable, and without measuring ACT, you cannot predict anything.
Yeah, we need to wait for 2 more minutes for the ACT results to come. 2 or 3 minutes. We have sent the blood sample. We'll get it shortly.
So, Shiva, everything is now somehow stable. Let's have
Put the aortic pressure now. So RA mean now the aortic pressure is stable. So what's going in that 10 ml? That's NORAD. Okay, how much of NORAD is it? 0.2. Okay.
Shiva.
79%.
Shiva.
Yes.
Now let's discuss a little bit. I think one of the big advantages of the Occlutech AFR device is that as you did, you can put this in, wait, assess, wait longer, assess more, and then you have the possibility and option to take it out and upsize or downsize it, whatever it's needed. In this case, Dietmar, Franz, and we all think downsizing may be worthwhile thinking of.
Yeah. என்ன நெஞ்சில பெயின் இருக்குல்ல relax the pain will slowly go out. Yeah, he feels a sort of a chest discomfort. Some of these patients will have left main coronary compression caused by markedly dilated pulmonary artery also. Okay. So the aortic pressure has stabilized. RA mean pressure is around 12 now, I think. Yeah, it's around 12. Put the hemodynamic screen bigger. Yeah.
How many liters of oxygen you have now?
83% on, what is that, 10 liters roughly. still, still he is fully not fully awake. Are you able to like breathe comfortably now? No? What, you are having breathing difficulty or? Rumble. Okay. He says that he is marginally improving. 84% on this supplemental oxygen.
Tell us, what is your plan now? Do you want to decrease the oxygen and see how the saturation behaves?
Yes, I'm going to do that, but see, since he had just one episode of syncope a short while ago, I'm just allowing him to stabilize the cerebral ischemia to completely sort of normalize, and then I will do that. Rather than say you saw his systemic pressures going down to 30 millimeters of mercury. Aortic pressure was 30 millimeters when I was like loading the AFR. So let this perfusion completely normalize. He's having a stable aortic blood pressure now, so a few more minutes, then we'll see. He was completely not responsive to nitric oxide. A short while ago, we were checking the nitric oxide responsiveness. He had the same PA pressures on and off nitric oxide. One another possibility is IV sildenafil, whether we can try to give, but I don't know what is going to be the impact. His sats are now 87%.
We would propose that you have some more time for observing the patient and then make the decision a little later, and we would start with our first lectures. Is this all right?
I think that is perfectly fine, but I think it was a great illustration of this particular procedure, how it actually the severe pulmonary hypertension produces a hemodynamic syncope due to very low left atrial pressures, very high right atrial pressures, and how these patients get into their episodes of syncope, and it was a good possibility to observe that live on a given occasion. You continue with your lectures, and probably I will, in another 15-20 minutes, after a couple of lectures, you can come back.
Yes, but the point is, don't finish it's not finished yet. We still have to decide whether this device is the appropriate size or not.
Yeah, actually I'm keeping I'm keeping a 6 AFR ready, but I'm going to take a decision another 10-15 minutes later, depending on how he stabilizes, what is his oxygen levels. I normally will be happy to see a saturation at the end of the procedure anywhere between 88 to 90% on room air breathing. So
yeah, we fully agree, but without supplemental oxygen.
Correct. Right now he is on 89% saturation on supplemental oxygen. We will slowly reduce it in the next 20 minutes, and I will come back to you.
Okay, so thank you very much for the time being. Wonderful case.
So let me tell you what happened after that. The blood pressures, show me the aortic pressure. The blood pressures remained stable. We had tapered off the norepinephrine from the original dose of, put it on 200 scales, 100 scales. What is the dose of norepinephrine now? 0.05. Okay, the norepinephrine dose has been reduced to 1/4 of what it was going above. He's out of oxygen now. He's saturating around 92 to 93%, and his the AFR 85 measures around 6 millimeter. I feel, and now I have a catheter that is crossing into the left atrium through the AFR. Now I'm going to pull it back into the right atrium. Can you put the LA scale on LA scale on 20 scale?
So what you tell us that you have absolutely perfect situation when you have a 6 millimeter hole.
With this particular orifice, he is saturating somewhere around 93 to 95% now. Reduce, increase the speed. Further increase. Yeah, speed. No, not that way. Reduce the speed. Reduce the speed. I'm going to pull back. So from LA to RA, I'm going to pull back. Still, the LA pressure is only around 2. So now I'm going to come back into the right atrium. That's the right atrium. The right atrium is now about 8. The left atrium was 2. There is a gradient of around 6 millimeters between the two. I will show a intracardiac echo big color off. Okay. Bhushan, can you hold it in this way? So right now I'm giving a small flush on the right atrium. So you are able to see the color flow, like the saline flow that was crossing through. Can you see that? Did you see that I was flushing the sheath?
Yeah, we saw it.
Okay. So there is a fair amount of communication. I think I'm going to release it. The transient hemodynamic syncope that was happening was possibly because of his little fasting state, and as I told earlier, normally an AFR will be the first patient in my cath lab on a morning.
Shiva, one question concerning the flow reducer. You are much experienced. When you implant an 8 millimeter or 10 millimeter one, do you assume that you will have at the end 1-2 millimeter less than the real or the true hole is, or not?
Exactly. 8 millimeter AFR in a normal atrial septum gives anywhere between 5 to 6 millimeters. A 10 millimeter
Okay.
AFR
Yeah.
anywhere gives 7 to 8, unless you have done some pre-dilatation with some larger balloons. Sometimes we do that when we want a significant reduction in the RA pressures. Then we pre-dilate the atrial septum with a 12 millimeter Boston Scientific Mustang balloon, which is a low profile balloon, and then put in the 10 millimeter AFR device so that it doesn't shrink much. Currently this orifice is measuring around 6. It's through the thin portion of atrial septum, and so that is the reason why it has expanded reasonably well. His saturations are reasonably okay. In fact, right now it is somewhere around 95. So things are looking fine. I'm going to release the device because and your question on the ACT level, it was 350 plus, and so the anticoagulation part was adequate. So now the release part is something simple. So it's released now. Can you show the color flow now? Actually, can you appreciate the color flow that is? See, the intracardiac
Yes,
echo is not
nice
as
picture.
nice as regular echocardiography. Like for probably a transesophageal echo would have given an even better picture. Can you see the flow through the center part of the device?
Yes, we can see that.
The metal does not allow a good Doppler to go through through its fenestration. So show the aortic pressure again. Aortic pressure again. Change the scales. 100. Yeah. Okay. The rhythm is stable. Just increase the speed. Show the rhythm strip bigger. Yeah. Show the hemodynamics bigger.
So
Yeah.
you have mentioned that this patient is on some form of anticoagulation beforehand.
Already. Yeah.
Okay, so you don't change anything in that.
Yeah. Actually, I would add aspirin in addition to anticoagulation, because I feel that an atrial septal surface also needs an additional antiplatelet. Put the thoracic echocardiogram and show an epicardial, an apical 4-chamber view. As I'm talking, my colleague is changing over from the intracardiac echo probe to the routine apical 4-chamber transthoracic echocardiogram. Normally, I do these procedures on just simple echo guidance. It's not very common for me to put in an intracardiac echo probe. However, in this particular patient, the atrial septum was bowing quite substantially, and I think that was quite useful to have got in an ICE probe. Now, what you are seeing is the apical 4-chamber view. Can you make the echo bigger? Echo bigger on the screen. Yeah. So Dr. Raghu has got the, still the atrial septum is significantly bowing towards the left. Saturation is around 93. I'm going to give a last contrast echocardiogram. It's just an agitated saline, not an agitated saline. Actually, it's a saline that is going through the sheath. Just show the, now I'm going to inject. You can appreciate the amount of saline that was passing through from the right atrium into the left atrium. RV dysfunction is continuing. I probably might give a small dose of milrinone throughout the night for him, and then slowly taper it off tomorrow. You're feeling okay now? Huh? Relax. Okay, the operation got over. So You can appreciate that. Show a nice 4-chamber view, the entire right ventricle, so that they can appreciate the RV dysfunction.
When I analyze a patient with pulmonary hypertension, my most important view is on the mitral flow inflow.
Yes.
So I think you have now a quite better mitral inflow,
Yeah.
and that is related to the clinical condition of the patient. So I don't need the right pressure and whatever, but the inflow over the mitral valve as the most important parameter in relation to the clinical or hemodynamic situation.
Yeah. You can also appreciate a small amount of pericardial effusion that the patient was having. Yeah, grossly dilated inferior vena cava, pericardial effusion. These are all prognostic indicators in pulmonary hypertension.
Shiva, it was a great presentation. Thank you very much. We appreciate it, and greetings to Chennai, and we have to go further with the next talk here. Thank you very much.
Thank you.
Great. I'm a fan of you. You know it.
Thank you very much.